Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Paul, are you excited to do yet another video with tips for, I guess we could say, dental care or oral care for the internist?
It's a topic that usually fills me with a little bit of anxiety, but I felt much better prepared after going through our episode with it. I think our guest was phenomenal and gave us a lot of great practical tips to help me out with some common concerns.
Right. So Dr. Lisa Simon was our guest, a former dentist, now internist. And Paul, what did she tell us about dry mouth? Any tips there?
Oh, tons of tips. So it's a common concern, and lots of things can do it. So you can think about like autoimmune diseases, things like Sjögren's, I think sort of classically, and those patients, when you're doing your exam, may have fairly striking pathology. Like you may actually see the tongue, she said, might even be reflective because it's lost the papilla, so it's so kind of shiny and sort of bright and uniform in appearance. Patients may report they have to drink a lot of, this is not exam finding, but they have to drink a lot of waters to even be able to talk, or they have to stop in the middle of a sentence, or you may even see like their teeth kind of stick to their lips or vice versa. So before, if you can't blame an autoimmune disease, she did talk about other things that we could look for. So medications are a common culprit, particularly ones that actually have some anticholinergic side effects, like your antihistamines that have some off-target effects. And then she also gave some tips for how to manage that, which include things like sipping on water or artificial saliva, and then also sucking sugar-free candy. And she did emphasize, please do make sure it is sugar-free to best preserve the teeth while you're sort of taking care of the dry mouth. It's a very common concern. I feel like I hear a lot about it. I feel sort of better equipped to help patients with it now.
And then, Paul, a condition or a concern that I hadn't really thought much about, but I guess that dentists are much more aware of than we are, is the fact that nifedipine specifically, among some other medications, but can cause gingival hyperplasia. And this is especially in patients with poor oral hygiene to begin with. That tends to really, I guess, maybe be more fuel for the fire. But nifedipine, and it seems like it's dose and duration dependent as well. But this is something that I hadn't thought of. I mean, I tend to use a lot of amlodipine for blood pressure instead of nifedipine just by habit, I guess. But this is something that I hadn't thought of. I'm not sure about you.
I was aware of it. It's not something, unless a patient brings it to my attention, it's probably not something I'm actively looking for. It apparently can be really bothersome to patients. Typically painless, I believe she said, but also can be so substantial that like there's surgical intervention, like we're shaving down gums if you're unable to correct it by dose reduction or oral hygiene, that kind of stuff. So it can be a real problem, which I have happily not run into too often.
And she mentioned that it does seem like it gets it's kind of this bulbous growth of the gum tissue around the teeth. And she did mention that it will regress, like if you take them off the agent, or sometimes if you just lower the dose of the agent. So something to think about. Now, Paul, another thing that commonly comes up in primary care, and you're America's primary care physician, is bisphosphonates. And I always worry about these. Am I going to cause osteonecrosis of the jaw to one of my patients? And do they need a drug holiday if they're already on one and going for a dental procedure? So that situation, Paul, someone that's on a bisphosphonate going for a dental procedure, how should we counsel them?
Yeah, so largely, Dr. Simon, I believe, is kind of agnostic about the prospect of a holiday from bisphosphonate therapy if the patient's already taking it. I think we've all gotten the forms that, ask if the patient can have it, if it can be stopped for them, or if we need to stop it. But in general, it doesn't seem like there's a whole lot of evidence to support doing that. So at least in Dr. Simon's expert opinion, she does not believe it is necessary to do a bisphosphonate holiday for these patients who are undergoing things like extractions or dental procedures.
And I've since read other sources that say the same thing. They say some dentists might say they want them off it for 2 months before and then resume it once the complete dental work has healed. But that's not an evidence-based thing, and I don't think that's necessary as of what we know right now. The other thing I just wanted to point out is that the incidence of osteonecrosis of the jaw much higher among patients getting it for often like cancer therapy related indications for osteoporosis. It's a much lower risk, mostly because they're on oral bisphosphonates, which is a less intense therapy. And I guess, Paul, the final thing that I just wanted to bring up in this video is it always comes up, but your patient is going to the dentist, they're on some sort of anticoagulant or antithrombotic, antiplatelet agent. What do we do with that, Paul?
Dr. Simon says, and this is consistent, I think, with a lot of guidelines, that in general, there's no reason you just continue the things is the long and the short of it. There's lots of things the dentist can do to achieve hemostasis, which is the obvious concern. So she made the point that, for instance, rather than extracting all the bottom teeth, doing them one at a time, or you may need to throw in a suture where you ordinarily wouldn't, or you might have the patient bite down on gauze a little bit harder. But in general, the risk of things like thrombotic events or like in-stent thrombosis or something scary like that is sufficient that they should probably just maintain on those therapies in most instances, and the evidence does not support stopping them because they can do other things to stop the bleeding.
Yeah, and then she may check an INR 48 to 72 hours prior to a dental procedure. Not 100% necessary, but that, if someone's INR is elevated, that might alter the plan. But otherwise, yeah, there's not, it's recommended to try to continue the agent if you can. So please listen to the full episode. You can click on the link in the transcript below. And with all that, until next time, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole. Paul?
And I remain Dr. Paul Nelson Williams. Thank you and goodbye.